Hi everyone, welcome to another year with our multi-heart clinical and imaging lecture series. It's a real honor to have today Dr. Krishna Patel that will be starting this season with a cardiac PET for comprehensive ischemic heart disease assessment. It's a real honor to have her here today. Dr. Patel is an assistant professor of medicine and population health at the Icahn School of Medicine at Mount Sinai, where she's also the director of cardiac PET at Mount Sinai Morningside Hospital. She's an advanced multimodality cardiac imager and an outcomes researcher. She trained at Mid Medical Heart in Kansas City and at Brigham, where she did a combined program for outcomes research and imaging, and her research is growing, and you'll see her, I think, more often as a rising star. So Dr. Patel research examines how to appropriately use imaging results to inform clinical decision making and improve patient outcomes, with a special focus on older adults and on patient-centered outcomes such as symptoms, function, and quality of life. She's a member of the board of directors of the Cardiovascular Council of the Society of Nuclear Medicine and Molecular Imaging. She's a graduate of ASNAC Leadership Development Program and co-chair of the ASNAC PET Protocols and Tracers Guideline. She has received multiple NIH grants and has been a Young Investigator Award finalist at AHA, AHA Core, and ASNAC national meetings. Thank you so much for joining us. We're really looking forward to your lecture.
Thank you, Dr. Slipsuk, for the invitation. It's really an honor and a pleasure to be here to talk about one of my favorite topics. Am I audible? Is the volume okay?
Yeah, perfect.
Okay, wonderful. All right. These are my disclosures. They are not relevant to the content of this talk. And before we talk about PET, I just wanted to preface by talking about the changing epidemiology of ischemic heart disease and the reason why we're why I'm giving this talk today. So we know for the past few decades now that the rate of non-obstructive coronary artery disease is increasing in patients who have ischemic symptoms. These are data from more than a decade ago from a Danish registry, which showed that about 33% of men and two-thirds of women who had symptoms and underwent angiography actually had non-obstructive coronary artery disease. This is similarly data from ACC NCDR registry, which showed the same thing, that 3 in 5 patients who actually had angiography for anginal symptoms did not have obstructive coronary artery disease. And then we know from this and CT data also that this non-obstructive coronary artery disease is not a benign condition. Patients who had diffuse non-obstructive coronary artery disease, in fact, did have higher rate of death and adverse cardiovascular events compared to reference population and patients with completely normal coronaries in this NCDR data from a while ago. We also know that other cardiovascular diseases such as heart failure with preserved ejection fraction are rising due to rising cardiometabolic risk factors. And we know that these patients who have HFpEF or who develop HFpEF, a significant proportion of them, as you can see in this study, have both obstructive coronary artery disease as well as coronary microvascular dysfunction, or a combination of both, which is common and often unrecognized. So while traditionally most of the non-invasive diagnostic modalities are focused on kind of identifying, diagnosing obstructive coronary artery disease, now we've started to recognize more and more that it is very important to diagnose patients with non-obstructive coronary artery disease and diffuse atherosclerosis, as well as patients with coronary microvascular dysfunction, which make up for the majority of the patients with ischemic heart disease and are not benign conditions and are associated with high cardiovascular risk. So now let's talk about how we can use stress cardiac PET to differentiate these different phenotypes of ischemic heart disease, and how it what are the unique properties of stress PET in comparison to the other modalities, diagnostic modalities that we have available to us. So what information do we get when we get a cardiac, when you order a stress PET perfusion imaging study? you do get your reversible perfusion images, which is what you see here, which are what you're familiar with when you also read SPECT, where you're looking at relative perfusion. So you're looking at tracer uptake in different regions of myocardium at stress and at rest. And what you're comparing is decrease in tracer uptake in the region which is subtended by a coronary artery which is critically stenosed, with the idea that the perfusion and the tracer uptake in that particular myocardium will be low compared to the other region, and that's what we've typically used all of these years to diagnose significant epicardial coronary artery disease using nuclear perfusion imaging. So you do get that, where we look at extent and severity of reversible and fixed perfusion defect, and we also compare size of LV cavity at rest and stress, and look for things like transient ischemic dilation, which is increase in cavity size at stress, which is what is present in this patient, which is another high risk marker. But in addition to that, you get function information. How is function information that you get from PET different than what you get with SPECT? With PET, usually the stress, we get both rest and stress wall motion as well as function, but the stress function that you get is obtained at peak stress, compared to with SPECT, where we have to wait for the technetium, the subdiaphragmatic uptake to go away before we make. So typically stress images are taken 30 to 45 to 60 minutes after the peak stress, whereas with PET the function evaluation is typically at stress or like very close to stress in with some radio tracers. So the wall motion that you get, the function that you get at stress is more sensitive, right, to pick up ischemia versus SPECT. And the other kind of important metric that you get from this information is this information about drop LVEF reserve, which is basically stress minus rest LVEF. So if there is a drop in EF with stress, just like how you'd interpret it on stress echo, it is a poor prognostic marker, and often suggestive of high risk multivessel coronary artery disease. The third piece of information, which you get from most PET MPI studies, as they are done on PET CT scanners. So all PET scanners, all PET MPI studies, mostly they're done on PET CT scanners. You always get coronary artery calcium information. A lot of times, if the patient does not have a known diagnosis of coronary artery disease, we kind of perform a typical coronary artery calcium score. But regardless, even if we don't perform it, everybody has a low dose CT scan done for attenuation correction, which can and is used to give information about calcified atherosclerosis, which may be subclinical in a lot of patients. But one of the most important information that you get from a stress PET is it gives you the ability to quantify the actual blood flow that reaches the myocardium at rest and at stress. So the ability to quantify flow to the myocardium is one of its kind of unique properties, and we have lots and lots of data to kind of support how it helps us in diagnosis, prognosis, and management. So you get stress and rest absolute flows, and then we measure something called myocardial blood flow reserve, which is the ratio of stress to rest myocardial flow. So reserve tells you how much does your flow go up when the patient gets a vasodilator stress test. So let's talk about why is stress better. The radio tracers that we use to perform PET are positron emitting radio tracers. They are better than the typical SPECT tracers. And how are they better? So these are the perfusion radio tracers that are typically used for PET perfusion imaging. Rubidium and ammonia are most commonly used, and fluoropyridaz, F18 fluoropyridaz, is a newer radio tracer which was just recently FDA approved last year. You can see here that typically the half-life of these tracers is very short, and because of that, they're associated with a low radiation dose to the patient. So typically, with an entire rest stress rubidium study, the radiation exposure to a patient is quite minimal, about 2.5 to 3 millisieverts for the total study. Similarly, with an ammonia study, also it's 1.5 to 2 millisieverts, much lower than what you'd get with a traditional spec study. Similarly, the other kind of important characteristics of all of the PET tracers, now some are better than the others in this regard, are that they have a higher first pass extraction. What does this mean? So you can see that these are like the curves for technetium tracers that we use in spec. And these are for rubidium, ammonia, fluorpyridaz. So ideally, the ideal perfusion radio tracer, the uptake of the tracer within the myocardium should be parallel to the uptake, should be parallel to the blood flow that reaches the myocardium, right? Because that's the kind of basis of perfusion imaging. So you can see here this 45-degree line, which is oxygen water basically has 100% extraction. That's perfect. The closer the tracer is to this kind of 45-degree line, that means that the actual extraction of the tracer within the myocardium is kind of more parallel to the blood flow that reaches the myocardium. And what does that mean? That means that there's going to be higher counts within the myocardium. There's going to be better resolution of perfusion defects. It is going to be easier to detect milder perfusion defect, and you're going to be able to more precisely quantify blood flow. So all of these characteristics, because the first pass extraction is better, it makes it easier for us to detect a perfusion defect and ischemia if it exists, which contributes to the increased sensitivity that we get with perfusion imaging with PET and low false negative, exactly. The other important thing is, of course, PET is better technology. It has better spatial and contrast resolution, higher count density, and all PET is attenuation corrected and scatter corrected. And why is this important? Like we don't really ever, we never, because all PET is attenuation corrected, we would never see breast attenuation artifact or diaphragmatic attenuation artifact. So when you see an abnormality, it is very likely that that abnormality is real. If you see a perfusion defect, because of all of these characteristics and less artifacts because of that, you're more likely to have disease, and that contributes to the high specificity and low false positive rate associated with stress PET. Stress PET is quick, with a typical rubidium, rest stress rubidium protocol. This is the protocol. We start with a topogram, we do an attenuation map, and then there's a 7-minute rest acquisition. We give vasodilator, and then 7-minute stress acquisition. So the whole study is really done within 18 to 20 minutes, and the patient can be in and out within an hour. And we have all of the information that I just spoke about at our disposal to help understand what's going on with the patient and why is the patient having symptoms. So we talked about myocardial flow quantitation with PET. PET is currently the most accurate non-invasive means to quantify absolute myocardial blood flow and flow reserve. And as we talked about the traditional perfusion imaging, the relative perfusion images that we see, these are relative images. So it assumes that the region which has normal tracer uptake, it assumes that the region is normal. Which again is flawed, right? Because if you have kind of more diffuse disease or microvascular disease, you're not going to see, if you have more extensive disease or balanced ischemia, you may see normal tracer uptake and still miss significant multivessel disease. A flow quantitation with PET does not require any additional time or radiation. You just do the 20-minute protocol that we discussed, and we post-process the images. It's the same study. We obtain kind of arterial input function, tracer uptake. We use a software which looks at how much uptake of the tracer happens in the myocardium over time from the kind of arterial system, how much is retained and how much is washed out, and it gives you quantification of flows in all LV segments, stress, rest, and then the flow reserve, which is the ratio as I mentioned. And in converse, I mean, how is flow reserve, coronary flow reserve, myocardial flow reserve, as we like to call it with PET, the way that it is different with FFR is that FFR really looks at pressure drop, right, as a surrogate for a drop in flow across epicardial stenosis. Whereas myocardial flow reserve, we're measuring the flow in the myocardium and we're looking at how much the flow rises. So it kind of takes into account any disease that occurs in the entire coronary circulation, including the epicardial as well as the microcirculation, which is how it can also help us diagnose microvascular disease, which some of the other measures cannot. So let's look at some examples to see how stress PET, what it offers in addition to other modalities when it comes to diagnosing obstructive epicardial disease. So this is a PET on a 74-year-old man with multiple kind of cardiometabolic risk factors who's been presenting with increasingly worsening exertional dyspnea. And if you can see, there's a small amount of ischemia that's present mainly in the base of the basal kind of inferior region, early RCA territory, but the perfusion otherwise looks okay. So I would say that this ischemia is about 5 to 6% of the myocardium. But the question is, when we just look at these relative images, is this just disease that is local to just RCA? Or does this patient have more extensive disease given that he has high risk factors? Does he have more multi-vessel disease that might be contributing to this picture? Patient also could have diffuse atherosclerosis. And based on this test, the other question that arises is how should we optimally manage these patients? So flow in this information and also coronary artery calcium that we get with a PET can help us differentiate this images, differentiate this in this patient. So when we look at the coronary calcium in this in this patient, he does seem to have kind of extensive multi-vessel coronary artery calcification, which makes you wonder, right? Is this patient having multi-vessel significant coronary artery disease, or is this just kind of diffuse disease and the focal disease is significant stenosis is just limited to RCA? When you look at the flows, the stress flows are reduced in all coronary territories, and the flow reserve is also reduced. So normal flow reserve or low risk flow reserve is considered to be 2 or greater. And the lower it is, the more likely that the patient's going to have multi-vessel disease. So especially if it is less than 1.5 or 1.6. So this patient had a global myocardial flow reserve of 1.5. Which again suggests that maybe this patient has more extensive ischemia that affects all three coronary regions and not just the RCA. This was later confirmed. So whenever you see this pattern of abnormal perfusion in any coronary territory, even if it is small or subtle, with global myocardial flow reduction, it should always raise a concern for potential multi-vessel high-risk epicardial coronary artery disease, which is what we found in this patient who had both left main and multi-vessel disease and later underwent bypass surgery. Now, this is kind of another example of a similar type of perfusion defect, reversible perfusion defect in the inferior region at kind of the base to mid. You can see here that this patient also has kind of just RCA territory, ischemia or reversible perfusion defect. Now, this patient has a history of coronary artery disease with PCI in LAD and extensive non-obstructive CAD in CIRC and RCA, who's presenting with chest pain. When you look at his flows, while the stress flows are reduced in all three coronary territories, the flow reserve is reduced only in the RCA and it's preserved in the LAD and circumflex, which tells me that the circumflex, the LAD and the circumflex have non-obstructive coronary artery disease, but the RCA region is the one that actually has obstructive CAD. And again, the global flow reserve is preserved. So when you kind of see this pattern where there is just regional reduction in stress flows or regional myocardial flow reserve, but normal myocardial flow reserve in other territories, that typically suggests that there's just single vessel involvement of epicardial, significant epicardial stenosis, which is what we found in this patient who had significant RCA stenosis, but the LAD stent is patent and there was non-obstructive disease in the circumflex. The other kind of example here is, it can also help us uncover kind of significant epicardial CAD. I want you to kind of just focus on the relative images on the left initially. So when at the first look, if you see, overall the perfusion looks relatively okay. There is this kind of subtle perfusion, reversible perfusion defect, which is very, very subtle, that you kind of see here in kind of like the mid lateral region, and then little bit here, kind of at the apex. But it's quite subtle. It's very mild, and kind of hard to catch. If like even the computer basically called it normal, right? But then when you go and look at the flows in this patient, you see that the stress flows again are reduced in both LAD and circumflex, meaning that this kind of subtle defect that we see is real, right? And again, so here kind of let's not focus on the reserve, because the reserve is also affected by the rest flows in this case, which are elevated, and that's why the ratio has gone down. But here the RCA has preserved stress flows, the LAD and circumflex I have reduced stress flows, which suggests that there's potential LAD and circumflex disease. This was a patient who had very high calcium score, had a normal SPECT, and was having a little bit of dyspnea. And because he had all these kind of risk factors and mild dyspnea, and the calcium score was quite high, he actually was sent for a PET even after his SPECT was normal. And you can see here that the patient had kind of mid-distal LAD disease as well as circ disease, which is what the PET showed, confirming there's kind of these subtle defects that we saw initially on the relative images were in fact real. So this kind of, those were kind of case examples of how we, the improved kind of sensitivity and of PET, quantitative PET, right? The one that you not only look at the perfusion images, but also flow. We have scientific data to prove that. So this is one study which I like showing because it was a prospective study where all patients underwent all three non-invasive modalities that were studied, and then everybody had a cath with FFR for gold standard diagnosis. So among patients on the left side was the first for the first study where it was a diagnostic cohort. So these were patients who did not have known coronary artery disease at baseline. And there's a head-to-head comparison in 200 patients of PET, SPECT, and CT. And you can see here that quantitative PET, in this case, it was done with oxygen water, had the highest diagnostic accuracy compared to SPECT and CTA. They did do a follow-up with FFRCT, and the accuracy of PET was similar to FFRCT, but FFRCT was not evaluable in about 25% of this cohort. Similarly, in patients who have known CAD, which was defined as those with prior MI or revascularization, they saw that PET was more sensitive and had numerically higher diagnostic accuracy, even though it was not kind of statistically significant because the confidence intervals were wide compared to SPECT and MR. We have some randomized data also to kind of support this. So this was the DAN NICAT 2 trial, where patients who already had significant stenosis, more than 50% on CTA, so patients with obstructive coronary artery disease on CTA, rubidium PET versus CMR were evaluated in a randomized fashion as kind of second line. And they saw among 372 patients that so PET here on the right had kind of higher, slightly higher overall diagnostic accuracy compared to CMR. Whereas, I mean, the specificity of both studies was quite good, but when you combine both, the accuracy was a little bit higher. And all of this kind of just goes on to show that you cannot equate the perfusion, the severe ischemia or relative perfusion defects that you see on PET with what you see on SPECT. So we had this really unique data set that we took advantage of to look at this question. So we had 322 patients who got both PET and SPECT at the same time. And by same time, I mean that they got the same vasodilator. And the PET, the stress PET acquisition, typically we do it right after you give vasodilator, and SPECT we do it within like an hour. So using the same vasodilator injection, both PET and SPECT were like done in the same patient. So we had kind of paired images of PET and SPECT that was done at the same time in 300 patients. And then we compared. So how many patients with, and we just kind of took the cutoff that was used in the ischemia trial, more than 10%, to look at the discrepancy between how perfusion, what we see on perfusion PET versus SPECT. And these are all automated reads, right? So there is no kind of visual, kind of semi-qualitative component to it. These are automated, computerized reads of perfusion. And if you can see here, the first thing to note is that in the same patients, PET was much more likely to pick up ischemia. 94 patients had ischemia on PET compared to only 31 patients out of 322 actually had more than 10% ischemia on the SPECT. And then when you look at the patients who had severe ischemia on their SPECT, 42% of those patients actually did not have a corresponding significant ischemia on their PET studies, suggesting that maybe SPECT did not accurately assess the burden of ischemia in these patients. And when you look at the patients who had severe ischemia on PET, SPECT missed about 81%. So the ischemia was, burden of ischemia was lower on SPECT. It was basically called normal in about 18%, and then less than 10% in the rest. And only about 19% of the patients actually had both, you would call severe ischemia both on PET and SPECT. And we also kind of saw in the same study that PET was a more effective gatekeeper of downstream testing and can be used to reduce inappropriate downstream testing. So in this study that I just mentioned, all the patients got both studies done at the same time, but they were randomized to receive only one report. So either the doctor, like the referring doctor, got the PET report or the SPECT report. Now the primary endpoint, which was kind of diagnostic failure, the number of events was very, very low. So we did not have the power to kind of analyze the difference between PET and SPECT in this study. But what we saw is that the patients who had high risk MPI findings, just perfusion, relative perfusion PET, were much more likely to get to be referred to cath and revascularization compared to if they had a high risk finding on MPI. And conversely, the low risk finding, the doctors are much more likely to believe a low risk finding on a PET and less likely to refer the patients to cath or revas compared to those with low risk findings on SPECT. And these are all patients who already have established coronary artery disease. And again, just to kind of follow up on the slide, on the last slide, patients who had severe ischemia on PET, either they had both, ischemia on both PET and SPECT, or just on PET and not SPECT, were really the ones who are getting revascularized downstream. But if if you had discordant findings, meaning that if you just had ischemia on SPECT and not PET, none of those patients actually ended up getting revascularized, suggesting that they were probably artifact and false positive. This all goes on to suggest that it's just because of the kind of better diagnostic properties of PET, it's just a more effective gatekeeper of downstream revascularization and angiography. So let's talk about some of the other metrics that we get on a PET study. So the one thing that I mentioned is LVEF reserve, right? The stress minus rest LVEF. So normally with PET, because the EF acquisition occurs at peak stress, the EF should rise by about 5% with stress. But if it drops or if it doesn't rise, then that basically means that there's more ischemia in the patient. And a blunted or negative LVF reserve basically suggests that the patient has more extensive kind of ischemia and extensive multivessel disease. All right. So, I mean, as with every non-invasive study, we know that perfusion and all the other measures that we get with PET all would have prognostic value. But, it's more important nowadays, or I mean, I feel that, yes, we know that, yes, it's all prognostic, everything has incremental prognostic value. But what would be more meaningful would be that, well, is it really going to help us change management or not? Right? The real purpose while we're doing the study is also to identify patients where we're going to kind of change our management downstream, either send them to revascularization in case of obstructive coronary artery disease, or manage them medically. Now we know that the ischemia trial, where half of the patients had SPECT and the other half had a combination of stress echo, CMR, and exercise treadmill, there was no difference in invasive management that was based on ischemia versus medical management over a period of 4 years. But why is that? We asked the question, well, is it because that the imaging modalities that were used in ischemia were not sensitive enough or accurate enough to pick up accurate high-risk patients? And can we further refine the selection of who is an ideal candidate for revascularization with a better modality such as PET, which allows for more accurate representation of the ischemic burden of a patient? So we first started to assess it using just the relative perfusion, similar to the image that you've probably seen in many talks on about the Hakamovitz study, where you see that the patients with more than 10 to 15% ischemia actually have a lower rate of adverse cardiovascular events, a lower rate of death with revascularization versus medical therapy. So we kind of replicated that, and we saw the same thing with PET relative perfusion imaging or PET ischemia. So anything below 1, so these are all hazard ratio plots, right? So this is a spline plot where we're plotting the hazard ratio with early revasc versus medical therapy across different percentages of ischemia. So anything which is a hazard ratio less than 1, that means that the patients have a lower rate of death in this case with revasc compared to medical management. And anything above 1 is higher risk with revasc, right? So you can see here that the patients with more than 10% ischemia, 8 to 10%. So the cutoff with PET is a little bit lower, again, because of the difference in diagnostic accuracy. More than 10% ischemia had a lower rate of death and revasc with medical therapy. And then, but we do know that just relative perfusion, we saw all of these examples which showed that just relative perfusion imaging doesn't give the whole picture, right? You may miss balanced ischemia. Relative perfusion imaging may just underestimate the extent of ischemia, like we saw in this patient that we saw before with multivessel disease. Or sometimes you may have completely normal perfusion and still have multivessel disease, which would be picked up on the flow. It is not as likely to see completely normal perfusion with PET and high risk left main or multivessel disease because it is a better technology. So the balanced ischemia that we talk about all the time with SPECT, that, oh, we might be missing multivessel disease or high risk disease, the rate with SPECT is about 15%, right? So these are patients with left main disease where about 15% had completely normal perfusion. And when we look at the same percentage, or what is the proportion of patients with high risk multivessel disease who have completely normal perfusion on PET, the number is much, much lower. So out of about 330 patients, only about 10 patients actually had completely normal perfusion on rubidium PET. So the rate of kind of completely normal perfusion is much, much lower, 3% versus 15% that has been reported with SPECT. And in all of these patients, the myocardial flow quantitation, the LVEF reserve, and the other high risk like measures such as TID will pick up or will help you identify multivessel disease with PET. Similar to perfusion, the patient has a drop in LVEF reserve, has a negative LVEF reserve or a zero LVEF reserve, have higher risk of adverse cardiovascular event. Similarly, with even with myocardial flow reserve, we have data across multiple centers now that show that patients who have a low myocardial flow reserve, even if their perfusion is completely normal, like you can see here in 0% ischemia, those with a lower flow reserve actually have a higher risk of adverse cardiovascular events than that. But then we asked, Well, can we use this data to help us refine our management practices in terms of who actually will benefit from revascularization downstream? So we looked at the like large data set that we used to look at the ischemia question first. We had more than 12,000 patients, and we found that only patients who had a global myocardial flow reserve of, in this study, 1.8 or low, were actually the ones who were having a benefit with revascularization versus medical therapy. So you can see this is kind of the benefit. The less than one is the benefit quadrant, right? And the patients who had kind of preserved global myocardial flow reserve values who did not would not necessarily have at least a benefit in cardiovascular risk reduction if they get revasc. You can see here, so how you can use both the perfusion assessment and myocardial flow reserve together. So even among patients with more than 10% ischemia, only the ones who have a low global myocardial flow reserve are really the ones who are going to benefit with revascularization in terms of cardiovascular risk reduction. And whereas patients with preserved myocardial flow reserve, they're not going to necessarily get a benefit with revascularization, suggesting that medical management might suffice for these patients. We kind of saw the same thing with LVEF reserve also on PET. So for patients who do not have known CAD, those who had a zero or a blunted, a negative LVEF reserve were the ones who actually got a benefit, and there was no really benefit if the LVEF reserve was preserved. And this was independent of flow reserve. So this was not, so this is either or. So if you either have a low LVEF reserve, or if you have a low global myocardial flow reserve in addition to a perfusion defect, then those are really the patients who are going to benefit from revascularization. Otherwise, medical management is sufficient. We did not see the LVEF reserve pan out in patients with remodeling, such as patients who have prior MI or revascularization, but it existed with myocardial flow reserve. You can use it in all patients, but with LVF reserve, you want to kind of use it for more patients, diagnostic patients who don't have extensive coronary artery disease. And again, we saw the same thing that, even if you have perfusion defect, those with the, who have significant ischemia that is going to make their LVEF reserve go down are really the ones who are going to benefit, and not the ones with the preserved LVEF reserve. So how do we kind of put this all together, all of these kind of different components on PET together to identify which patients are really the patients who are going to benefit from downstream revascularization? And this, we're just talking about obstructive CAD, right? So in addition to, so in patients who have kind of more than 5 or 10% ischemia, but also have either a drop in LVF reserve or a drop in global myocardial flow reserve, are really the ones that should be referred for revascularization. Otherwise, medical management would suffice, even if there is more than 10% ischemia in the patient. So when we see these two patients that we talked about initially, both of them have some degree of kind of RCA ischemia, but the one on the left had a significant drop in global MFR. The LVEF did not augment with stress. So this is the patient on the left is the one that is going to benefit from revascularization, versus the patient on the right, given that the global flow reserve is preserved, and the LVEF reserve is okay, it's 5. This patient can be just treated medically despite of the ischemia. Now, when we talk about this, when we talk about imaging modalities, we usually just look at cardiovascular events, and the prognostic utility and management and all of this is, usually evaluated in terms of cardiovascular disease endpoints and mortality. But the other kind of important treatment goal in ischemic heart disease is patient health status, right? Quality of symptoms, function, and quality of life. So I'm going to, because we might run out of time, I'm going to kind of just quickly skip through this. We know that, so what we first found is that quantitative measures of ischemia on PET are strongly associated with patients' symptoms, function, and quality of life. In patients, 1,500 patients who underwent PET, we saw that, when you kind of quantify, just because it's more accurate, right? It's more accurate representation of ischemia, nothing else. They kind of strongly associated with SAC summary score, which is a combination of anginal symptoms, functional status, and quality of life, and then Rose dyspnea score, which is dyspnea related health status. So you can see here that all the quantitative measures are very strongly associated with that. So then because of that, patients with ischemia on PET should be more likely to have better improvement in angina and quality of life with revascularization compared to medical management. Which is what we kind of also saw in this kind of small pilot study, secondary analysis of that, the 322 patient trial that I mentioned, where we saw that the patients who had more than 10% ischemia actually had a better odds of improvement in angina frequency and a better odds of improvement in overall health status with revascularization compared to medical therapy. This was confirmed in the ischemia trial. But the other thing that the ischemia trial also brought up was that, oh, 1/3 of the patients in ischemia did not have any angina initially, which led people to say that, oh, you don't really need ischemia assessment. You just see if the patient has symptoms, and then you revascularize the patient just based on the symptoms and anatomic extent of CAD, and the patient will benefit. But we actually showed that it is the symptoms that are related to ischemia. The improvement in ischemia is in fact what is improving the symptoms, function, and quality of life. So in this kind of small pilot study of 75 patients, we saw that the change in SDS, so less improvement in ischemia will lead to less improvement in symptoms, function, quality of life. Less improvement in myocardial flow reserve will lead to less improvement. So again, it is the mechanism of symptom benefit with revascularization, which is obvious. It has to be improvement in ischemia, but was first kind of proven by this pilot study, which we're currently publishing. But you see that all of these coronary artery disease trials, even though PCI improves angina, a lot of patients still have residual anginal symptoms. So even in ischemia, only about 72% of the patients in the invasive arm were angina free compared to 61 in the conservative arm, which makes you think that is one of the reason that they're still having symptoms is because they have kind of microvascular disease that has not been treated with revascularization. We saw that, the follow-up MBFR, so these are patients who got a PET before and after revascularization. So the myocardial flow, after the patient has been revascularized, the myocardial flow reserve is going to pick up kind of any residual microvascular dysfunction that exists in these patients. So we kind of also concluded that yes, the residual microvascular dysfunction is potentially one of the reasons why the patients are still symptomatic. 1 in 4 patients are usually, that's the statistic that we quote, that they're still symptomatic even after revascularization, and this may be one of the reasons. So the way that we put all of this together is that the larger the severity of ischemia, this is all related to obstructive disease. The more the myocardium is affected by ischemia, the larger the therapeutic risk reduction with revascularization that you're going to get. This is a graphic that was originally created by Dr. Shaw, which I really liked, and I adapted it for PET. So her hypothesis was that if there's not a lot of ischemia, initially you're just going to get an improvement in symptoms with revascularization, right? Because you just have a little bit of ischemia which is causing your symptoms, and it's not going to really lead to a reduction in your cardiovascular risk or reduction in your MI. But if you have a large enough area of ischemia, then you're going to get benefit in cardiovascular events and MI with revascularization. So the parallel of how we identify severity of ischemia with PET is those who have milder perfusion defects, just regional flow abnormalities. Those patients will probably just get an improvement in their symptoms, function, quality of life if they do get revascularized. But when the ischemia is large enough and it starts affecting the function of the study and the global MBFR, so when you start seeing a drop in LVEF reserve or resting LV dysfunction or a drop in global myocardial flow reserve, that means that the ischemia is extensive enough that you're going to now get a therapeutic benefit with in terms of cardiovascular risk reduction when you revascularize this patient compared to just medical management. We're going to spend maybe briefly 5 to 7 minutes talking about the non-obstructive CAD. I know we're kind of running out of time. So again, I think picture speaks louder than words. So let's look at this patient. This patient has a calcium score of 300, little bit atypical symptoms, comes in, has a stress PET, has these results. So you kind of see this kind of subtle anterior reversible perfusion defect, right? When you look at the flows, the stress flows are reduced in that region of that you see the anterior perfusion defect, but the flow reserve is preserved in that territory. So when you see this type of pattern where the stress flow is reduced but the flow reserve is preserved, you should think, hey, does this patient have kind of diffuse non-obstructive disease? That in itself is not enough. You need other things to also kind of improve the confidence that this is in fact diffuse non-obstructive disease. But this is an indication that maybe this is, even though we see a perfusion defect, this is not obstructive CAD. So what can you use? You can use a metric called relative flow reserve. So what is relative flow reserve? Relative flow reserve is the ratio of stress blood flow in the affected territory, in the region of the perfusion defect, to the flow in a reference territory. So you need, this can be used in one vessel or two vessel disease. You obviously can't use it in all three vessel disease. You need a normal region. So this is basically stress MBF in affected region divided by stress MBF in normal region. Whatever that ratio is akin to what we call FFR. Initially, invasive FFR was first validated against this metric. So you can use this similar to how you'd use FFR to detect whether this is obstructive versus non-obstructive. The other thing that has been proposed to be used, it's more sensitive in just LAD for now, just because of the tracer, where you can kind of see, is it a sharp drop in flow from base to apex, or is it kind of like a more gradual drop? So if there's a sudden drop, then it's more likely that the stress flows in the affected territory, then it's more likely that this patient has obstructive CAD, versus if it's a more kind of gradual drop, then it's more likely that this is diffuse disease. So let's look at this example, right? So here you can see that it's 1.6, 1.6, 1.5. So there's really only a gradual drop. But when you calculate the RFR, it's 1.6 divided by 1.8, which is about 0.9, again, which gives us confidence that this patient, even though they have perfusion defect, likely is from diffuse non-obstructive coronary artery disease. Let's look at this example. Now, this patient has completely normal perfusion, has all of these risk factors and multiple ongoing symptoms, ER visits for ongoing symptoms. She's had a CT at some point in the past, which showed non-obstructive coronary disease. So here, she's getting this PET, the perfusion is normal. There's not really a lot of coronary calcium, but the coronary flow reserve or the myocardial flow reserve findings show a diffuse decrease in myocardial flow values, stress myocardial flow values in all coronary regions, and a decrease in myocardial flow reserve to about 1.7. Now, this pattern in this patient, now that we've already ruled out significant epicardial coronary disease, is diagnostic of microvascular dysfunction. So the flows in this case helped us indicate the presence of CMD and suggested that there is, in fact, suggests high risk of adverse cardiovascular events, and finally gave her a cause for why she's symptomatic. I'm going to kind of skip this talk about coronary microvascular dysfunction. We know that this is microvascular disease is basically abnormal vasodilation of the microvasculature, which we cannot see. And that's what the MFR on PET is trying to identify. It's very prevalent. It affects about half of all men and more than half of all women who present with symptoms. It can exist with obstructive coronary artery disease, and it can also exist without obstructive coronary artery disease. And again, if you do have CMD, we now know that it is associated with a high risk for future HFpEF. This is kind of one of the seminal studies from Viviani Taketi at Brigham, who showed that those patients, even if they had abnormal diastology, only if they had a low CFR did they have a really high risk for future HFpEF hospitalizations and future HFpEF versus if their flow reserve was preserved or reduced, but they did not have abnormal diastology. This suggests that flow assessment on PET can help us understand subclinical microvascular disease, which may be one of the mechanisms that links cardiovascular risk factors such as cardiometabolic, obesity, diabetes to elevated heart failure risk. And as such, we can use PET flow in asymptomatic patients to identify high-risk patients where early preventive therapy could be started. This has been, this kind of increased risk in patients who have a low flow reserve has been shown across a lot of different clinical populations, has been shown in patients with asymptomatic diabetes, patients with metabolic syndrome, patients with autoimmune rheumatic diseases, rheumatic arthritis, SLE, psoriasis, also like valvular diseases. So again, showing that you could use, this is aortic stenosis. The last slide was hypertensive heart disease. I'm not going to go into detail for the sake of time, but again goes on to show that maybe in the future you could use, how we use non-obstructive atherosclerosis as early risk marker. Similarly, you can use microvascular assessment of flow abnormality in these high-risk populations to identify candidates who should be aggressively treated early on to reduce their future risk for heart failure. And now, I mean, all of this was retrospective data. So you might argue, well, do you have any kind of randomized evidence to show that flow-based management would actually improve cardiovascular outcomes? So in fact, now we do. So this is the Century trial, which was recently published in the EHJ, where 1,000 patients were randomized to what we call a standard group versus a comprehensive group. Only about 6% patients in either group actually had severe reduction in flow and they were revascularized. But majority of the patients did not have severe flow abnormalities. And the comprehensive group actually got a lot of PET-based lifestyle and medical management and close follow-up, whereas the standard group just was treated as how they would be treated in a standard of care with their primary cardiologist. And they showed that the comprehensive group of PET-based kind of comprehensive risk factor management not only led to an improvement in their risk factors, it also led to a decreased rate of death or MI, and unplanned revascularization compared to standard therapy. Just 2 minutes for the new PET radio tracer called F18 fluorpyridase. We've been using ammonia and rubidium for like the past 20 years since we did PET, but now recently last year, F18 fluorpyridase was approved as another PET perfusion tracer that could be used. Some of the unique advantages of this tracer is that it has because it is F18 labeled, it has a longer half-life of 110 minutes compared to the 76 seconds with rubidium and the 10 minutes with ammonia. So because of the longer half-life, you can use it with exercise stress. The other ones, you can't really use it with exercise stress because there is not enough time. The tracer is going to die down before you can exercise and get the patient on the scanner. Versus with fluorpyridase, you can. And it also has excellent tracer characteristics, which can yield accurate non-invasive perfusion assessment for all patients. And the other important advantage is that it improves access to PET. Typically, you can only do PET if you have a rubidium generator or if you have a cyclotron in your system, or close by that can give you the ammonia. With fluorpyridase, you can just order a single dose like you do with FDG or with technetium, and maybe just do maybe 1 or 2 studies a day. You don't have to do like 5 to 10 studies a day for it to make economic sense. So it will significantly improve access. And because it is a better tracer, It allows us to also measure subendocardium separately from transmural assessment, which is what we typically do, which again improves the specificity. So you can, with CMR, stress CMR, you can separate out the subendocardium and also look at the transmural, knowing that ischemia starts subendocardially first and it's more sensitive, maybe a little bit more diagnostic accuracy, which is what you can do with fluid peridaz. We also have now data that shows that typically when you do exercise PET, you don't get flow assessment because you don't get the arterial input function, which is what you need, because the patient's not under the scanner because you're injecting the tracer when the patient is on the treadmill. But now there are initial studies that show that you can estimate, you cannot maybe directly measure, but you can accurately estimate flows using even with exercise stress PET data as seen here, if you just apply a correction factor. Similarly, because it's a better tracer, here now all the segmental flow abnormalities are much more reliable and much more sensitive with fluid peridaz compared to the other tracers that we've used. So these are kind of some of the main advantages of fluid peridaz compared to the other tracers that we talked about. Because of all the data that we have to support PET, both ACC/AHA as well as ESC guidelines kind of support the use of PET in patients with acute chest pain, stable chest pain, both with and without known CAD, and also in patients with suspected INOCA, which is a 2A. But you can see here in ESC, it's 1B for all of them. So all of this kind of goes on to suggest that now we have increasing evidence also, including higher quality evidence to support the use of PET over SPECT, and as one of the frontline diagnostic non-invasive modalities to for patients with suspected ischemic heart disease. So what's our take home? Usually patients with intermediate to high risk, where they're more likely to have disease, you want a more sensitive study. You should preferably use PET over other kind of physiologic studies or other non-invasive modality, because it will not only tell you if the patient has disease, it will tell you if the patient has subclinical calcified atherosclerosis, it will tell you if the patient has microvascular disease, and PET with all of the different measurements of ischemia that we get on a PET not only enables in improved risk stratification, but can also help us guide our management by helping refine patient selection for revascularization and also helping guide medical management. And then we also talked about how PET flow can be used as an imaging biomarker to identify kind of asymptomatic high-risk patient for certain special clinical populations, such as long-standing cardiometabolic diseases, inflammatory systemic diseases, valvular diseases, to identify patients who should probably get more aggressive medical management or preventive therapy to prevent their future risk for heart failure. With this, I am going to stop, and if there's any questions, I'm happy to answer.
Thank you so much, Krishna. This was an amazing lecture, so comprehensive, and I think, like I was telling you before, comes right on perfect timing, not just because of the growth of PET in the country, but also because we're launching new sites here at Montefiore. So we only have a couple minutes for questions, so we'll go through them. Aldo says hi, by the way. He joined the lecture as well. You can promote Aldo, Glenis, if you can, for a quick question. A last one from Dr. Travin. He's saying he asked about something that you showed. He asked about what is the meaning when you have high rest flows as well that lead and high stress, but you have a low ratio or a low reserve.
Yeah, no, that is very important point that I didn't get to go into detail because of this. So now, so because myocardial flow reserve is a ratio of stress over rest, there's two ways that it can go down. One is if the stress flow is down, which is what we typically hope to happen, right? Like if there is any disease inside the coronary circulation, the stress flow is going to go down and the flow reserve is going to be low because of that. Like that's like classical microvascular disease, classical epicardial disease. But more and more, we also see that the flow reserve is often low, not because the stress flow is low, but because the rest flow is high, because the denominator is higher than normal. So when does this occur? This usually rest flow in all of us is proportional to the resting heart myocardial work, right? Resting heart rate and blood pressure. So if you have tachycardia or hypertension, or in certain patients who have high sympathetic tone, such as obese patients, women, their rest flows are higher, regardless of what their heart rate or blood pressure is. So that now has been shown to actually be a risk marker, right? So that is not benign, as you can imagine. It's not the same as somebody who has normal heart rate and normal blood pressure. So again, now we realize that that should not be ignored. So we at some point we used to like do this rate pressure product correction of myocardial flow reserve and kind of normalize the rest flow to like normal essentially. But now we don't recommend doing that. So if your flow reserve is low, even if your rest flow is high, that means that the patient is at an elevated cardiovascular risk. The question is, the main thing to know is that it's not because of of significant CAD, it's because of the high rest flows, and you should address the rest flows using, medical management for that. So risk factor management for tachycardia, hypertension. So again, now we try to when we report, we no longer correct. We try to kind of separate out what the low flow reserve is from and then recommend a management accordingly.
Awesome. That's very good. Before we go to Aldo, I'll ask a quick question that I think is very important for everyone, and you work in New York as well. What's the status with insurance coverage for PET versus other modalities?
So, I mean, also for Medicare, all patients with Medicare are auto covered. There's no prior auth required, right? So, and this has been the case for many years. So, with Medicare patients, you don't have to worry. For patients who do not have Medicare, typically it was a lot of these kind of, Avicor people used to limit it to people with obesity, like more than 40, those who have prior equivocal studies, and then those who have like discordant studies or like like a artifact that was reported in an older study, things like that. So it was limited to certain age groups, but now we realize that it, like now that they know the benefit, now they kind of expanded. So it's no longer that hard to get prior auth. Most of the time it's approved. They don't approve the flow. The one thing to do, they don't approve the flow, but we do it as standard of care in everybody, and we bill for it so that eventually we get paid for flow.
I agree. Thank you very much. Aldo, if you want to do a last quick question.
Oh, absolutely. I mean, Krishna, it's nice to see you again. It's amazing. We know each other from a long time since medicine, and I mean, it's quite impressive how not only the field of PET has really evolved, but you have been one of the key members in kind of making that progress and taking it to the next level. I completely agree. I was able to watch your talk a little. Patrick, I was in interviews with the fellows, but the current way of reading PET is exactly what you mentioned in your talk. It's just kind of we look at everything. I mean, the heart is going to be looked at from every single aspect and every single optic that provide a comprehensive assessment, of the heart, all the way from the coronary calcification to the relative perfusion, but as well to the quantitation, and the quantitation with the PET FFR that you mentioned, which can really, provide a lot of guidance, above and beyond just whether you have or not perfusion defect, but what kind of or type of disease you have, and even macrovascular dysfunction, which is great. You were part of that work, as you show in your slide. One question I have for you is, if you have had experience with fluidas, what are the things that we need to be on the lookout as drawback? I mean, the tracer looks like it's amazing. I mean, the whole kinetics is exceptional. The half-life is great. But what are the things that you would say you have to be careful if you start using fluidas?
So this is an excellent question, Aldo. Sorry, I just want to do a disclaimer that we have not started using it clinically yet. So my, impression is just based on what I know, looking at images and kind of having discussions with other thought leaders. So fluoropedas is an excellent tracer, right? So 2 or 3 things that we need to kind of be mindful of, because the myocardial uptake fraction is much higher than, your rubidium and ammonia, you're much more likely to see perfusion defects, right? Because it's just much more kind of accurate to pick that up. The question is, and sometimes it might be milder earlier disease where they don't necessarily meet the anatomic criteria for coronary artery disease more than 50%. So what we don't know is, yes, you can see more issues, you can see more abnormalities just looking at perfusion, but whether or not, like what to do about it, whether or not it is clinically meaningful just because it's a better tracer and picks up more. The other thing that needs more validation is flow. right? So we have like these small studies that were done using secondary analysis of the phase 3 data, where the flows like make sense when you look at it on a population level. But the thing to remember, it's a very small subset. Not all patients actually got flow results. And when you look at independent studies, even within those phase 3 trials, there might be a lot of discrepancy. So how to best like opt what is a like how to best use flow with fluid pre-DAS, and because it's a better perfusion tracer, how much incremental value does it give to you just compared to your perfusion, is something that still needs to be kind of evaluated in the future. So I think those two would be the things that I would be mindful of. And I think the other thing is also you need to train our eyes a little bit, right? Because it's gonna show more abnormalities, so there's gonna be a little bit of learning curve there as well.
Absolutely.
Thank you very much. So this was an outstanding lecture, and I'll invite everyone to continue watching our lectures on Fridays for clinical and imaging. And Krishna, you're close by, so hopefully we'll see you around.
Of course, and thank you again so much for the invitation. I had a great time. Thank you.
Bye bye.
Bye.
Thank you.